Hi, this is Nick Cristiano from the New York State Hymns chapter, and we'll be starting in about 1 minute. Well, good afternoon, everyone. We want to thank you all for joining us. We're going to get started now. This is a co-sponsored event between the New York State Hymns chapter and the HFMA Metropolitan New York chapter. And we're bringing you the topic of top of mind health system innovation priorities 2021 and beyond. Little housekeeping as we start. This event will be recorded, but if you need closed captioning, there is a CC button on your video controls which you can employ, and it will turn on the closed caption option. Use the Q&A function for all your questions, and we'll be perusing your questions in the background and queuing them up for later on in the presentation. If you have any technical difficulties at all, just refresh your browser and you should be good to go. And we just want to thank you again. If you are not a HIMSS member or an HFMA member, please look us up on our websites. Also, if you have a scanner, you can scan the code and join us as a full-time member. We have these presentations literally almost on a weekly basis at this point in time, and we enjoy having you as attendees. At this point, I'm going to turn over the presentation over to Sam, who's our moderator. And Sam, you can take us through our panelists and then the rest of the presentation. So I'll sign off for now. Sam, good luck to you and all our panelists, and thank you again.
Thank you, Nick. I'm not sure why he wished me good luck. Apparently this panel can be quite spicy in some way. So I'll take your luck, Nick, and see what I can do with it. So thank you. My name is Sam Robinson. I'm Microsoft Chief Health Plan Officer. So of course, I'm here to talk to you about revenue cycle management on the provider side. I feel like I'm the enemy in infiltrating the camp at this point, but it's going to be a great discussion. We have a cavalcade of experts for you that are going to be talking to you about a range of subjects, what's happening with COVID, RCM, AI, and anything else that comes to mind. I want to encourage you to hit the little question mark up at the top, enter your questions. We'll be reviewing those and answering them either via the chat or via live, as we will have extensive Q&A following the more formal panel discussions. So onto our panel. Sean Barrett is the SVP of Product and Digital Transformation for R1, which is an RCM company. Andrew Marchese is my colleague and friend from Microsoft, and he runs a lot of our business around providers and EMR vendors and all of what we call our health solutions area. So med tech, health solutions. So he's going to be piping in about where the technology leads us. Leah Jones, SVP and General Manager for Allscripts on the ambulatory side. Melvin Hutchins, he's the global healthcare expert for UiPath, a RPA vendor. And Adrian Rivera, who's the CIO of Jadanis Limited and outsourcer for RCM and hospital billing. To start us off, I'm going to ask the panelists to just introduce themselves a little more deeply than I did and what their background is with the subject at hand, RCM, AI, and RPA, and how they have sort of led their individual groups. Let me start out with Sean. Sean?
Thanks, Sam, and hello, everyone. As Sam mentioned, I'm Sean Barrett, and I lead product and digital transformation for R1 RCM. For those of you who don't know, R1 is a leading provider of tech-enabled RCM services spanning the end-to-end revenue cycle process across all care settings. And today we manage about $40 billion in patient service revenue on behalf of our clients across all 50 states nationally. In my role, I really spend my time focusing on how R1 can leverage technology to truly automate, and I use that term with a capital A, the revenue cycle at scale through our built-for-purpose technology suite, machine learning and advanced analytics, and robotic process automation. Really excited for the panel today and look forward to the conversation.
Andrew Marchese, can you tell the folks who you are?
Hi, everyone. Excited to be here. As Sam mentioned, I'm an industry executive at Microsoft, covering our solution partners such as Allscripts and others, as well as the medtech space. And I do have a background as a CPA, so I think that's the finance connection. I love really, and have for the last 15 years, worked to map our platform and partners to key health initiatives with our key customers. So really excited to join the conversation today. Thanks.
Leah, can you tell us a little bit about your background and what you cover over at Allscripts? You're on mute, Leah, but your miming is good. I read your lips, but no one else can. So we need you to come off mute.
Is that better?
There, much better.
Okay, that's my first challenge. So Allscripts is a healthcare technology company that has products and solutions serving in vast areas of hospital and health and ambulatory practices. So within our business unit, we are about a $500,000 annual revenue and $500 million in annual revenue. And we have about 70,000 providers that we cover, providing technology solutions in electronic medical health records, as well as practice management. And really probably as much as anything relevant to this conversation is rev cycle management services. So we embody many experts, and our value proposition is we provide a full scale technology solution to our providers from beginning to end with capturing of clinical data, as well as payers and in the full cycle of revenue management for our clients. So excited to be here, and like Andrew, I am a CPA, so this is especially kind of fun for me to be involved in a financial kind of area of the business, even though I don't get to do that really daily. So thanks for inviting me, and excited to be part of the panel.
Maybe I'm starting to see why Nick wished me luck. I've got 2 CPAs now. Melvin, are you going to make it 3 on me?
No, I actually hate numbers. Melvin Hutchins here with UiPath. Thanks again for inviting me to participate in this event. I am a global subject matter expert here at UiPath, and really what that means is that I work with our sellers to really develop and our customers to develop solutions around robotic process automation and intelligent automation, because there is more to automation than just RPA. It's about including other technologies, building use cases that expand what you can accomplish to automate those processes, much like Sean had mentioned. But thank you again for inviting me, and happy to be here.
Thanks, Melvin. Andrea, can you give us a little background on what you do there at Genus?
Zanus. Hi, I'm Andrea Rivera from Zanus Limited. I've worked for Zanus for about 25 years. I started in the mailroom back in the 90s. And at that time, Zanus was primarily a servicer of hospital receivables. Today, we provide technology solutions in addition to being a servicer of hospital receivables. So we build out our automation based on real life experience that our own users are seeing. Like what are the use cases that we're finding as they work through receivables? So we take it from the perspective of technology and customer service combined from our own experience within the technology realm and with hospital receivables.
Thank you, Andrea. And we're going to start off with you, actually. So you've seen a lot of change from the mailroom. I didn't even know we still had mailrooms. So your career path is actually a path of digitization in the receivables. As you've seen the slow transition, have you seen any changes and any trends that have sped up specifically during the last year? I'm still trying to come up with a great name for it. I want to say the COVID acceleration is what I'll use for purposes of this call. But if anybody out there wants to suggest something more politically correct or appropriate, I'd love to hear it. So during the COVID acceleration, what have you seen change in the receivables market, and how have you adopted to it? Adopted it or adapted to it, I should have said.
We've seen a lot of changes post-COVID, and I think the COVID acceleration is an eloquent term. I like it. So if anybody has any other suggestions, great, but I think that's a good one. I think you just coined a phrase there. We definitely are doing so much more work from home than we ever did before. We had a few users working from home when the pandemic hit. And, you know, in the matter of a week or so, we had to get almost all of our users to being able to work remotely, which was definitely challenging, but at the end of it, very rewarding, because we found that most of our users are able to work effectively from home. You know, what we've seen on the technology side as a result of that is needing to develop more tools around productivity metrics and understanding what employees are doing throughout the day, so that management can make sure that they're tracking people's productivity and their work effort and the effectiveness of that work effort. And we found that that's where technology really comes in to help out the management staff.
Interesting. Sean Barrett from R1, you're largely an outsourcer and you provide a very customized service. How did that work from home transition that Andrea just brought up, how did that affect your company, and did you miss a beat? Were there some new things you had to discover and invent on your own to get out to your customers?
Yeah, it's a great question, Sam. I think we saw COVID really shake up our product roadmaps, particularly around our built-for-purpose technology, both to adapt from work from home, as Andrea mentioned, some of the performance reporting, real-time activity monitoring, and some of the collaboration tools that we had on our roadmap got pushed right to the front and got quickly delivered out to our operators. The other piece I'll add on to here in terms of product roadmap is launching our digital front door solution. So I think one of the big changes we all saw with COVID is the desire for many of the frontline staff. So think of this, your registration desks, your check-in desks that are actually facility-based and are R1 employees, trying to get a meaningful percentage of those folks back into remote locations, work from home locations, and how can we facilitate digital self-service of those same processes? So we quickly accelerated our already ongoing rollout of our digital patient experience platform that allows for digital self-service, patient digital scheduling, as well as digital interactions between their staff and our staff in a remote location. That was really well received actually by our staff and our employees to not have to be in the front lines anymore and be able to work remotely, as well as we got great net promoter scores from the patients that use the service as well.
Fantastic. So it sounds like digitization has started to take over and move into the forefront. Andrea Marchese of Microsoft, can you talk a little bit about not just your client base, because we have Leah here who's part of your client base. Leah can talk for herself, but and the broad range, what are you seeing from digitization trends? We heard work from home, we heard productivity, we've now heard the magic phrase digital front door. Are you finding a rush in your provider-based customers or Microsoft provider-based customers to any of those trends? Or are there other trends that you're seeing that were not only required but accelerated through the COVID acceleration?
Yeah, Sam, certainly virtual health obviously took off as a huge area. I think it went from 1% of primary care visits for Medicare up to 43% just in a 6-month time frame. So huge uptake, yet to be seen whether those levels will decrease back down or not. But the other example I would give is our bot framework. So Microsoft had in the year or two before COVID developed a health bot framework, which was really about surfacing a conversational agent on top of all these different data sources in an organization. And we saw some uptake for things like triaging or automating some call center functions. But boy, when COVID hit and health systems were suddenly really strapped and getting inundated with calls, people showing up at the ER and their nurse lines lighting up, that really, it was quickly adopted for a COVID symptom checker and actually got taken up by the CDC and other health systems to really offload some of those manual processes and still help people and serve up the correct information, still be very good about directing to the help needed if in emergency situations. But that would be one other example, was the health bot.
Fantastic. Panelists, anyone else that wants to jump in on the work from home, feel free. Otherwise, we'll move forward to our next area. So as you started to see the changes, there were a lot of regulatory changes that came down and keep coming down. We just saw a new version 7 of how to respond. I was thrilled that my vet can now give me a COVID-19 shot. I don't know if any of you are planning on that, but you might think about that. So we have seen a fast and flurry of regulations. How have your customer bases really taken that on? I want to start the conversation with Leah Jones from Allscripts. Given that your ambulatory focus, and we know how hard they were hit, especially early on, literally closing doors. Can you talk us through a little bit about how they adapted to regulation, or did they adapt? Is that part of their downfall?
Yes, thank you. It did happen very quickly, and our providers are not always Johnny on the spot with regulatory review and actually understanding it. So we found them reaching out a good bit for more education, and we were making every opportunity that we had to put education out onto our websites with easy access. But also we found ourselves calling into many of our clients from a rev cycle management perspective and trying to help educate them one-on-one, as well as taking their data and reviewing it and even augmenting their services to make sure we could review and we could correct transactions as they were actually taking place, so that we could ensure that their claims were clean as they were submitted. And we found early on that they were miscoding and they were delaying the receivables and the cash flow that they had. So we became a larger part of that, just simply continuing to review the education, continuing to correct data so that we could expedite their cash flow, because we knew that cash coming in the door was critical for many of our clients, because their number of cases and their patient visits were down significantly. But also, to add to a little bit of what Andrew was saying, we did see a lot of acceptance in new patient encounters that were via televisits, and that was a new business line. Really, while it had been out there, it hadn't been utilized by many of our patients. So utilizing the portals that they had already, that clients or patients had not adopted, more or less to the extent that it was required, our providers had, but really not utilizing that front door of sorts to communicate with patients. And so we saw needs there where we were having to help clients get the telehealth set up pretty quickly to utilize it, and then to make sure that the regulatory side of reimbursement was connected with that properly to continue that cash flow expedition. So it was quite a feat coming out of the gate. But what we found was once we had it going, the adoption became very quick, and it seems to have stayed. And I really feel like it's going to be hard to take back out of the patient's hands now that they're accustomed to it, as well as the providers.
Leah, thank you. We'll dive into telehealth in just a moment, but I did want to just ask you, it sounds like you moved from supplier, vendor to more consultant. Was that already part of your practice, or did you have to add in that consultative sales motion and consultative implementation motion to your process?
We've always, on our rev cycle management side, been highly consultative with our clients. We consider ourselves partners, not just vendors. So we've always reviewed data with them, talked to them about regulatory changes, and also provided a great deal of analytics around their data to help them manage their business. So this was just a new topic for us to introduce into a normal conversation and course of business. We're pretty high touch and high level of service with our rev cycle management. So it was new content, but existing relationships and partnerships allowed us to introduce that pretty quickly and easily.
So Melvin, coming back to something that Andrea brought up, how did your staff and staffing model have to change in this COVID acceleration? How did you move from, your current base of clients into how you had to help them transition, and how you're continuing to help, and what, if anything, is staying around about that new business model?
Yeah, so great question. Yeah, I wanted to kind of, before we get to that, double click back on regulatory. One of the things that we saw from a regulatory compliance as well, and this is on a global scale, was essentially all of the reporting that had to be done for testing and positive, negatives, and basically tracking every single test that was administered around the globe. So we saw a huge uptick in automation to automate that process. So essentially, as soon as a swab is done, the results are there. What you don't want is an epidemiologist to be fat fingering that into a system. So we automated that entire process for the entire country of Ireland and UK and Sweden, and with many of the health systems here in the US as well. So I think that back on the regulatory piece was that there was a big heavy lift just in changing how people assess that. But back to work from home and how we saw our customers. It was kind of funny. I was on the phone with the clinic, the Cleveland Clinic, and I was just like, it was my first virtual meeting with a customer, where they were at home with a fake background. And I was like, "Are you in the office, Bob?" And he was like, "No, everybody had to go home and we didn't know how we were going to do it." But if you think about that, how do you deliver care and also work from home? Because care is such the physician's hands are directly on you. So how do you manage a care process? How do you manage the ecosystem that is care and work from home? I mean, it's a really challenging thing. One of the things that we just kicked off, projects we just kicked off with Geisinger, was essentially to very similar to what Sean had talked about, which was eliminating the check-in process. But we wanted to go even further, not just automating the check-in process, but also automating the checkout process, so that when you're finished in the physician exam room, you essentially walk out, you go onto your phone, and you Venmo the money over for your copay, and then you're done. There's essentially, there is no check-in process. It's completely digital and completely removed from having to interact with the person at a front desk, if you will. So those are some of the things that we've been really challenged around. Is, once again, how do you provide care in a work from home setting? And that's easy if you're talking about CPAs. They can work from home fairly easy, I would imagine. But still, I think that when you're talking about care providers, nurses, clinicians, that is a hands-on business. So how do we make it less hands-on? So does that answer your question, Sam?
It does. Sean, did you want to add something?
Yeah, absolutely. So Sean from R1, I think at a macro level, we saw COVID put tremendous pressure on an already cost-pressured hospital system, right? And so when we think of where hospitals look to accelerate cost containment, administrative functions is always top of the list or near the top of the list, behind clinical or ahead of clinical care. We saw an influx into our backlog of various customers asking for help for a couple of reasons. One, I think they saw the need for technology to play a forefront in modernizing and digitizing the patient experience and the revenue cycle, and really looked at how they could make those investments with some of the cost pressures that COVID brought or accelerated. Separately, I think they also saw that what is a fixed cost operation for RCM in hospitals and health systems, meaning they have employees, they have salary, they have systems, trying to transition that to a variable cost model tied to actual cash collections or a maintenance patient service revenue became really attractive for them, because they saw the pain that fixed cost model caused in the COVID downturn. So I think those two things combined really accelerated our funnel. In the conversations we're having with clients, we also are seeing technology questions be first, where before it was around how are your operations, how do you service our customers, what are KPIs, what are your outcomes. We've now seen how can we digitize the patient experience, how do you apply technology versus just throwing people at the problem to really revolutionize the revenue cycle. And those conversations have been really fruitful for us out in the market.
Interesting. So the fixed cost model. So Andrea, if we could turn back to you for a moment, looking just at revenue cycle management, or RCM, as we'll say for the rest of this presentation, as if we're writing a white paper here. I want to explain what RCM is. RCM, what trends did you see in the COVID acceleration from your customers, and what do you think is going to be more permanent around the revenue cycle management process itself?
I don't see work from home going away anytime soon. I think that's something that's going to stay with us for a while. We definitely were able to see productivity and not see drops in what we're doing because of it. We also saw a drop in denials, no authorization denials, medical necessity denials, as a number of payers suspended those requirements. So that did help hospitals to get money in the door quickly. However, the fact that elective surgeries were closed for a time, that was pretty impactful on the revenue side, just closing out those ambulatory surgery centers and reducing the amount of elective care that was being given. I think we'll start to see that come back up, but we are seeing there's probably more demand right now for it because the hospitals are trying to get through their backlog. So we should start seeing these things come back quickly.
So when you say come back quickly, is that something that the payers are already reacting to, that, you know, this backlog coming in? Are you seeing it in chronic care or mostly elective?
Mostly elective. Mostly elective, yeah. I mean, I think payers are responding, but it's really more on the hospital side to make sure that they have the means to deliver the care.
Interesting. Leah, what about on the ambulatory side? What are you seeing accelerate in that world? And, you know, the equivalent of electives, are you seeing the specialists coming back, or are they already gone and there's no reviving them at this point?
Where we've seen the rebound has been very quickly in the elective space. So orthopeds, that's probably one of the largest, where people had postponed surgeries that now came back with a little bit of a vengeance. So that backlog is working through the system now. I think we've also seen, separately just from patient care, what we've seen is a need for our practices to maximize their schedule as they rebound, because they have all of these inbound patients, whether it's COVID or elective or family practice or, you know, just these chronic medical care. People are starting to try to get in, and you've got to make sure you manage your schedules appropriately. And we're seeing some optimization around schedule management from our practices to try to make sure they maximize value and see the patients that need to be seen. And they're still getting the requirements for telehealth. So what can they see via telehealth, and what can they see inside their doors, and how do they manage their days around that, right? So how do they think about their scheduling differently than they did in the past? How do they make time for televisits, and how do they then also keep sick patients with COVID or other, you know, major illness type things that are high risk outside of the office, and keep the patients that they need to see in the office that they physically need to touch. So we're seeing that discernment take place, and they're looking to technology to help them do that, so that they don't sit with mounds of paper closing their doors just to figure out how to manage their schedule and get all those patients that need to be seen in their different modalities into care. So that's been a change that we haven't seen so much of in the past, that seems to be really coming to the forefront. And to second what Sean was saying, that the need for not only work from home, but that variable cost structure, that is very real now, because of all the cost pressures of these providers and those long-term employees that went out for, you know, a variety of reasons. Some of it was because the business was slow, and some of it was because they had to take care of themselves and their families. So that support from our organizations like R1 and Allscripts and others that have taken that workload on and can provide that variable workforce for them dependably, as well as even privacy, security, technology-wise, and keeping their technology going when they're not sitting in an office, to be able to do that themselves. So that's another variety of where we've seen a shift.
So interesting. Let's stick with telehealth just for a moment. So are you finding, from a revenue standpoint, and this is for any of the panelists, are you finding the revenue coming in now is greater or less for those that are fully embracing telemedicine or telehealth or virtual health? They're all almost interchangeable. as part of their practice going? Or are they just adding it as a supplement to their practices right now? Leah, you already have the floor, so if you could start, and then Andrea, I'd really be interested in how you're seeing that trend in the hospital side.
I would tell you that it definitely has been a shift in early on in COVID. And now I think it's just another modality of care. So I don't know that it's going to take over their revenue share by any means, but I do think that it has augmented their ability to do service. I also think it's going to challenge bricks and mortar going forward about how they actually provision space. So it's going to make all of your medical practices really consider how much they are going to expand their physical space. And as they have the ability to contract that space, you very well may see them do that as a means of utilizing more telehealth. But I don't think it's gonna change their mix of revenue streams tremendously. I think it's just going to allow them to continue the revenue streams that they've typically had.
So no increase, decrease, just if you want to maintain, you better adopt telehealth. Is that your advice?
Oh, by far, because if they don't adopt telehealth, you're going to have every, entrepreneurial organization, including Amazon, pop up and say, we will give you telehealth. And I think the loyalty to a provider is going to be hard to gain from patients going forward if they're not willing to meet the patients where they are.
Andrea, did you want to jump in there?
Sure. I definitely agree with that. I think all organizations need to implement telehealth to a degree and continue telehealth to a degree because patients are expecting it at this point, and we definitely want to make sure that we continue to meet their expectations. I think we do see slightly less revenue incoming from telehealth as opposed to in-person care, but it also costs less to deliver. So in the long run, I think that those two things will balance each other out. The one thing I do see in telehealth and post-COVID, the post-COVID world is people being more willing to let technology bear the burden. And I think that that's another ongoing piece of that. The more willingness from people who've been in the industry for a long time to say, okay, let's do it through a technology as opposed to doing it through people.
So you're saying you're actively seeing that change in the customer?
Yeah, I'm definitely feeling it. I mean, if we think about it from the perspective of work from home, bringing in robotic process automation, bringing in AI, we see people being a lot more willing to let the technology bear that burden for them. Digital front door is a great example of that. Let a person go in themselves and verify their insurance, do their pre-registration and all of those steps online, as opposed to making them come in and talk to a person who's going to gather that information. The technology will do it consistently. It'll ask all of the questions every time because that's what it's programmed to do. Whereas a person can be having an off day and forget to ask one of the questions. If they forget to ask your secondary insurance, for example, the organization may not be able to bill that in the long run, right? So we just want to make sure that we're allowing the technology to bear that burden up front and throughout the process. And I'm seeing more willingness to adapt to that.
So Andrew Marchese, Microsoft, I'm going to ask you to jump in. This sounds too easy to me. Technology can fix it all. It's easy, and everybody's going to do, and it's all saying. Sean and Melvin are shaking their heads like, yeah, this was simple. Talk to me. Is this that simple? And if so, why hasn't it happened before this? And what challenges are you seeing in the base at adopting to this new technology?
Yeah, I
think
think
when you adapting, but you got the point.
I think it's super important for health systems and organizations to really look at that engagement strategy, that they're not throwing multiple different apps at their patients, right? That as consumers, we're used to a very seamless experience. You check into a hotel, you get a text message, how is everything? And so I think healthcare is now at a state where they really need to look hard at adopting that mindset and making things extremely easy for patients to get reactivated, to take advantage of the services available, and that in turn provides a rich set of data for the health system to do even a better job at predicting, alerting, and kind of reaching out to patients when the need is there. So I think that front door strategy that's been discussed is really very top of mind. I would say too, there's parallels on the back end, on the provider care team side. the systems that they live in, I think up to 50% of the time for care teams is spent in an EMR system. There are definite steps you can take to make that easier and to streamline and optimize workflows. Like Northwell, as an example, joint customer of ours in Allscripts, has put some apps on top of their underlying systems to really ease things like rounding, for instance, so that they can check off the key milestones for patients and really optimize their length of stay and keep them on course for their planned discharge date as one example there. So not to take it off the focus on the digital patient experience, but I think there are some parallels on the back end too.
Andrew, let's stay with that digital patient experience. I don't know if the panel realizes this because we're just in our own little world here, but we actually have people listening to what you're saying. And they really want to know more about telehealth, specifically patient sat. You know, all of us have gone to those visits. No offense to Leah and the great TouchWorks product, but I'm sitting there and they're in TouchWorks. They're not talking to me, and they're kind of sideways glance to me, and you know, maybe they ask me a question or two, and then they look at the screen. I have physicians that are my age, so they're looking at the screen real close, and then they're coming back to me, and I don't have this personal experience with them. Are you finding, I know Deloitte said there's a 50% higher satisfaction from patients that are experiencing a virtual health visit, but what are you finding in your base? And we'll start with Andrew and then move around the horn here. Are patients going to demand, first of all, are they happy? Are we moving up patient sat through virtual health, or are we decreasing patient sat because of technology barriers? Second, as you answer that one, think about, what does that portend for the future? Are we going to see more or less? Reimbursement aside for a minute, are we going to see more or less?
More or less telehealth, you mean?
Yes, ma'am. Andrew, you start. It seems like you have the floor. Nick decided you were the best person to answer that question. That was Nick. So we're going to give Nick the credit for choosing you.
Andrew and Andrea kind of sound alike. So
They do. I'm not. My friend Nick's doing a great job back there.
Yeah, I think we are definitely going to see more telehealth as, like I said, patients are growing to expect that, to appreciate it, to appreciate those few minutes that they get back by doing a telehealth visit and not having to drive in and park and go through all of those steps. So I think we're definitely going to see that increase over time, not decrease.
Sean, you're up.
Thanks, Sam. Yeah, I would agree. I think as we think about what's going on around healthcare, right? A lot of consumers now coming to expect, call it kind of the Uberization of healthcare. So I'm used to going to check in for a flight and having kiosks and everything on my mobile app. I'm used to be able to press a button and get food delivered to me, or press a button and get a car. I think now consumer expectations in the industry surrounding healthcare are now getting applied to healthcare. Going back to the question you asked Andrew quickly, I do think technology is sort of the easy part here. I think adoption and how you operationalize that technology within an already complex ecosystem is really, really important. So I'll use the digital patient front door as an example. We've seen kiosks in hospitals for 10 years, right? Why in the recent memory have we now started to see this adoption pick up? And at least in our one's experience, we put a lot of teams out in the field to actually bring that solution into operations, figure out patient flow, how that changes, figure out cadences to drive adoption, figure out how the role of the front desk changes from a enter of information to almost a concierge, almost think of like a hotel kind of check-in type function. So it's not just putting a kiosk in an operation and flipping the switch. It's really, how do you wrap around the ecosystem of operations around that technology to really drive meaningful outcomes and business value? And we've seen that approach really pay dividends. I can use the same exact examples for putting AI into operations, putting RPA into operations. I think, again, the technology kind of is the easy part here. And I don't want to minimize the technology lift, but it's kind of the easy part to getting adoption and getting operationalizing those technologies is really the challenge we've had, and really where we leaned in with resources and been successful.
Hey, Sam, it's Leah from Allscripts.
Hey, Leah from Allscripts. I was about to call on you. So you tell me what you want to say, then I'm going to ask you another question.
Okay, well, one thing I would add to that is I think we changed the role of a doctor long ago when we put technology in their hands. If I recall, when I went to the pediatrician as a child, you are moved to a room, you sat in your little room waiting, and at some point you heard some ruffling at the door, which was that your paper file that was in a file holder on the door or near the door, and you knew immediately that your doctor was coming in. And as soon as your doctor walked in, he would say, "Hi, Leah, how are you? It's been a year since I've seen you. You've grown 2 inches." And he had this way of being very personable, but it was because he did not have to stare at a screen, and he had what he needed in his hands as he walked in the door. When we put providers with that art into the science of technology, we change their world. And we as technology providers have to give them back that mojo that they had walking in the door, being the smartest person in the room, knowing everything about you and recognizing you. And we've changed that a lot. So as patients, we have to be willing to balance the science and the technology with what we remember as doctors. So we've got to balance that. As technology providers, we've got to get them back that information in their hands on the screen where they can see it immediately, easily prep for an encounter with a patient. But at the same time, as a patient, we have to realize there's so much technology that they're using, and they're trying to document at the same time and make it an efficient and effective process while they're on the phone with you and in this telehealth visit or in this video visit. So that documentation is happening simultaneously, but we've got to give them the time to be able to FaceTime with the client or the patient as well, right? So it all has to blend in and balance itself. But we as patients have to realize that it's a different experience and there are pros and cons, but not having to travel into an office, not having to impact yourself with all the risks of being in an office with pandemics, actually being able to sign up and not leave your home. That's going to come at a cost because technology is involved in that, and technology is clunky at times, right? It doesn't matter if you're doing FaceTime with a friend. It's going to have its issues, but it's going to be you're going to miss that hand holding, that personal touch, that personal encounter with your provider as you benefit from the technology of being able to stay and the convenience to stay at your home. So we've all got to adjust in different ways, and it will never be the same as being in an office. But if you can get the right outcome, the best outcome, at the most effective and efficient encounter and modality possible, we should be willing to balance that as patients and providers.
Leah, great point, and thanks for bringing back the memory of my pediatrician visits with the paper file. I love that picture. Melvin, can you make it happen? Can you get the doctors the equivalent of the information on the paper file and the back-end processing so that they don't have to focus on the EMR?
Yeah, I think we're really close to getting there. We're getting ready to kick off a big project that essentially very similar to what Andrew described at Northwell, where essentially we're putting automation in the hands of the providers so that essentially there are just fewer clicks that they have to do to navigate the systems that they need to, one of which is the EHR. For example, one of the projects that we're kicking off is automating the discharge process. So if a provider comes to the EHR to discharge a patient and everything is there ready for them, so they're only spending 20 minutes in the EHR finishing up their documentation, canceling out orders, finalizing anything else that needs to be done. They're more likely to do that because it's just inherent in human nature that if I know that I'm going to have to spend an hour going through paperwork, I'm going to wait till the end of the day to do that or until the last moment. So, when Andrew talks about creating, virtual rounding or the ability to go into an EHR and instantly through two or three clicks be able to complete all of the data that they have to put in or the compliance work that they have to do in order to get reimbursed for the work that they've done. So yeah, we're on the cusp of launching these programs. We've done the research right now. I would say within the next 6 months, we will have probably 2 or 3 customers live where each provider has a robot that essentially does work for them. And it works with the human as well. So it's not just providing tasks and providing executing on items. The robot is executing work and then going back and validating with the provider, is this what you wanted me to accomplish, yes or no? So that the physician is still providing their intellect into the process. We've already had 2 or 3 pilots that we've done on small case studies. In one, it was California Correction Health Institute. It's the hospital system for the California penal system. And, you know, in that case, we saved the providers because they were having to reduplicate orders. We saved the providers about 2 to 3 hours a day per provider. And to me, that to give that time back is just astounding. Yeah, I think that as we look at the clinicians, if we can impact them in a meaningful way, that's going to have the biggest impact to the bottom line. I was actually talking to my brother-in-law this weekend. He's a CFO at an Allscripts hospital, or they use Allscripts at their facility. I think the bleeding's not done yet. You know, he said from a corporate standpoint is that he still has to cut, 15 more FTEs. And because just of the reduction in the receivables that they have. And I was just like, well, is it a specific area where where are you looking to cut it? It's like they don't care. They just said we need 15 more heads on the table. And if you think about that, I mean, what are you going to do? These are people I've worked with for 10, 15 years, and how do I decide what department that I need less effort from? Less human capital in. So I think that as we look to the future, technology will help. It's not going to solve everything, but it will be a key component to make us more efficient at the delivery of the care process. And I too agree with Leah on the pediatric visits. I definitely enjoyed that. But I have to come clean. My family doctor today is Kroger. So.
We're working on fixing that one on the other side of the house. So, unfortunately, you did. Thank you, Melvin, for mentioning something financial in that, because I think we're satisfying the HIMSS half of our webinar sponsors, but we're leaving short the HFMA. So I promise just one more HIMSS level question, and then we'll move back into RCM and AI and our RPA. So Leah and Andrew, doesn't matter which one of you go first. Let's say Leah first. The question becomes not in duplicating an entire visit. So as we've said, okay, COVID accelerated telehealth. Leah, Andrew, you mentioned, look, if you don't make this part of your book, you're going out of business, right? You got to replace that revenue, and that's where it's going to come from. Given that, what about all the other stuff? Who draws my blood? Who takes my blood pressure? Who takes my weight? Hopefully nobody right now for me. I'm enjoying that COVID expansion. But who does all that, and how are you seeing IoT and other devices play in this, and where are you seeing complementary services? And frankly, are you going to see some of the providers move into those secondary services like lab draws and other things? Or are we going to look at, CVS, Walgreens, Amazon Cares? Where is that going to come from? So Leah, let's start with you, and then Andrew, if you could chime in on the technical aspects of actually doing that. Like, what is standing in our way from getting consumers to draw their own blood or perform their own open heart surgery, or wherever you want to go with it. Leah.
Sure, thanks, Sam. The Internet of Things has been challenging the healthcare community for quite some time. Innovators have been coming up with different devices. I mean, I think about the Fitbit that I have on my arm today, but there are many ways to collect health data, and many of them sometimes you don't even know is collecting health data. Like your Apple devices that you have every day. That data can be consumed by the electronic medical health record systems, and it is many times with Bluetooth type devices through digital front doors, healthcare portals, etc. That information has helped with chronic care management for some time. And now I think it becomes even more so important with the advancement and utilization of telehealth. And I do see more devices that are coming out that will be probably part of health plans where you're given digital scales, digital type Bluetooth blood pressure cuffs. Even they have devices now that can be used for looking at eyes, ears, nose, and throats that can provide eyes to situations that weren't there before. I think for those who have chronic care management, they're used to the blood check systems that may become part of everyday life for us as part of telehealth. I'm not really sure about heart surgery. I think I really want to go in and see a provider for that. But I do think there are going to be things like blood draws where you're going to have these pop-up labs like Quest and LabCorp, et cetera, where those people play a larger role in day-to-day healthcare where they haven't. This is the exact scenario we've ended up with COVID tests. Think about that. Think about the vaccinations. You could never go get a flu shot really from your vet, Melvin, or who was that said that? Maybe it was Sam that said you could go get a COVID shot now from your vet. But who would have ever thought that we would be doing this type of testing at drive-through windows at CVS? But I do think your distributors like CVS and Amazon and Walgreens, Walmart, Target, Publix, all of those vendors are now going to play a much larger role in day-to-day healthcare because they have the logistics and venues of care to be able to do it.
Andrew, how do we get all right, maybe not open heart surgery, but how do I get lab tests at home? How do I get scales? What's stopping us from using the COVID acceleration to get more IOMT devices or IMT devices in some of the locations Leah mentioned, a Walgreens, a CVS, a Walmart, a Target. Where are we and where are your customers specifically and what's stopping them from moving forward?
Yeah, Sam, I think this is something we could do an entire session on this topic. It's as Leah mentioned, with the advent of wearable technology, now, I mean, you have EKGs that are wearable. The question of how do we harness that information and really do the right thing with it is key. I think the name of the game is ecosystem for the health customers out there to look at how do they partner with some of these emerging capabilities or make that decision that they're going to compete or, or cooperate. So it's really a matter of having a flexible, agile, interoperable framework for all of your systems so that when a technology emerges that can deliver better quality at a lower cost, you're set up to integrate with that and focus on your core competence. So I think that is a huge area right now. Retail, telehealth, those are all, and device manufacturers are all getting into the game. And so I think that space around care management and even chronic disease management is going to be somewhat up, for partnerships or competition going forward. I don't know if I answered your question here, but
no, that's very good. So again, we're being paid. This is HFMA as well. Let me switch topics to how AI has infiltrated your business. So let's start with Sean. And Sean, if you could start with what is AI in your business? Let's define it. Is it me talking to Siri, or is it, robotic automation of manual tasks? Define AI for me in your business, and then tell me how you're incorporating it and how it's helped with the adoption of technology moving forward.
Yeah, absolutely. Thanks, Sam. I think I take a pretty broad lens to the umbrella of artificial intelligence or AI, and basically saying anything that allows technology or systems to mimic human behavior. So that's everything from rules-based expert systems to computer vision and optical character recognition to natural language processing to machine learning. I know it's a bit of a gray area, but RPA I kind of lump into that same umbrella, given it leverages a lot of the, at least modern RPA, leverages a lot of the technologies I just rattled off. And so if you think about that AI umbrella, essentially we use that in a few different ways within R1. I think the biggest way is to solve, I'll call it the last mile problem. So we all know in healthcare, there are a lot of antiquated systems. We all that don't expose modern interfaces or modern interoperability to exchange data or to actually work in those systems. And so we use RPA to solve that last mile problem of getting data in and out of systems that don't have, I'll call it, better ways to do that, right? Don't have APIs, don't leverage HL7, don't have modern industry standard interfaces. And the revenue cycle is full of processes where essentially we're swivel chairing information from system 1 to system 2, or trying to get information out of system 1 and then do something in system 2. Everything from status of claims to whether an authorization is there to exchanging data between hospital systems and payer systems, where again, FHIR and some of those standards just haven't caught up to what we need. But I do think that that's the, I'll call it, that's the arms and legs of automation, right? Actually transacting at the user interface level against all these disparate systems. Upstream from that, though, there is an intelligence component, right? Where I think machine learning and some of those expert systems really comes into play. So think of that as the brain of automation. So what do I do next? What status should something be in? Who should work that? And so you have all those technologies that digitize unstructured data. So think of digital paper, bring that to a structured form that then I can take action on or write rules against, flowing that through a rules engine or through a machine learning model to figure out the what do I do, and then using RPA at the back end to actually transact in those systems. The one other piece I'll mention here that we found really successful is making sure we have humans in that loop. It's really hard, we found, to automate 100% of the volume in a very complex process, and you'll spend probably 80% of your time trying to automate the last 5% of the volume, because those are all the edge cases or all the random things that could happen that are really complex. And so the approach we've taken is let's automate the 95% of a volume for a given process, use a workflow platform, whether that be our proprietary workflow platform or within the EMRs or patient accounting systems themselves that can drive workflow, to send that 5% exception rate back into human hands to go work that exception and then move on, rather than trying to really automate an end-to-end process, which is really expensive to do.
Very helpful. Andrea, I know you've been instrumental in bringing AI into your company in general, but specifically to the hospital receivable side. Can you tell us, first of all, how you define AI in that case and what you're doing with it?
So we distinguish between AI and RPA, as AI is something where the machine's doing the learning for you, right? So in an RPA environment, you know what you want to accomplish, you know how to accomplish it. So it's really just programming the computer to take the steps that you want it to take. In that way, I consider RPA as low risk because it's not really making decisions for you. It's following a set of rules that you've given it. And we've seen that machines do that consistently. You give it a set of rules, it follows that set of rules. And in that way, it helps enhance the process because a person has an off day, they make a mistake. So we're able to use RPA to do probably 80% of what a person was doing before. Like Sean said, there's always going to be that fallout where a person needs to come in. We did bring in AI as well, saying like, you know, there's some situations where we don't know exactly what that deciding factor is that's going to tell you what should we do? What's the if then here? If this, then that. We don't know the if in some cases. So we use AI to take a look at a set of data and try to figure out what that if is. The challenge to it is making sure that you have that right data set. Because if in your data set there's a lot of errors or there's inconsistencies, the machine's not going to be able to make the right decision about what to do next. So just making sure that you have the right training data and that you're able to apply it to a large enough data set that you can figure out those results.
Helpful. And Andrew, are you seeing AI penetrate other areas other than RCM and other process automation tasks?
Oh, yeah, definitely. I mean, the whole ability to reason over vast amounts of diverse data sets, structured and unstructured, it presents a great opportunity. You know, the early use cases were things like identifying patients at risk for readmission, and you know, there are definitely financial implications there. But now that the onus is on really optimizing resources in return to elective procedures, et cetera, if you can identify risks that would prevent that procedure from going ahead early and intervene, like those are huge gains for health systems. So I mean, it's important to really take into account the social determinants, like, you know, does a patient have transportation? You know, do they have the information they need coming into this procedure so that we're not going to have to pull the plug at the last minute and reschedule? So I think, you know, definitely it's one aspect that's driving and an important area for optimal scheduling as one example.
Very helpful. Moving back to revenue cycle management for a minute, and feel free to add AI into that. what are you seeing? So we're seeing a rise in value-based care in general. Let's start with Leah. Is that in value-based care, what is the role of RCM, and does it go away altogether eventually? I realize these things are slow in coming, and the wave of value-based care is a very slow rolling one. But are we entering the days where RCM is no longer?
So I will say that value-based care got a really good look during the pandemic, because when providers were episodic in nature in terms of their care and volume, they began to realize that a fixed fee for a client or a patient, I think it was kind of the same, so I'm sorry for using that, but when they began to look at that and think, wow, if episodes are going to go down, having a fixed amount to care for this patient would help us during these ebbs and flows when more pandemics may come in the future. But I will also say that value-based care is kind of a look back. So the transactions are not going to stop. You're going to continue to see these pay for service, and we're going to have to become we're going to have to process those, but we're going to have to become really great at the analytics and reporting, because as we look at the value-based care and marry that to the activity that's happened, we're going to have to look at how much it took to care for that patient, how much they were allotted, and they're going to have to manage their business with that and also report back on it. So I think it's going to make the role of RCMS, or our Rev Cycle Management Services, just as applicable, if not become more analytical and consultative to these organizations to make sure they're balancing the episodes and the economics of that with the value that they're going to be given for those patients, to ensure that they don't lose money. So it may change a little bit from applying cash so much as, how do we manage these populations? How do you see the amount of transactional volume that's happening with these patients compared to what you're allotted, and throwing those flags and highlighting scenarios early on where you may be seeing leakage and where you're not managing properly. So it may shift our work a little bit, but I don't think any of it goes away, because it's probably going to be a little harder to manage in the future versus less.
Melvin, I need you to jump in here. Tell me, we automate this whole thing. Why do I need RCM in the middle if I already know my fixed payment? Come on, give me a bot. Let me just do it.
It's kind of interesting that. So I had the opportunity to spend quite a bit of time over in the Netherlands, and had worked for a company over there. And there is still a process, even when you're talking about elective surgery, there's still a process for patient qualification and the need to have that elective surgery, because someone is still paying for it, so to speak. So I think about, if we go back to kind of the AI, the model that we were talking about before, one of the things that we're seeing right now as a real trend within our US-based customers is the automation of prior authorization and utilizing AI for that. So if I can automate prior authorization from the provider perspective, and essentially have a bot go to the published requirements from that specific payer and adapt what is required from the submission of the clinical relevance, then that geoplasty process that typically would take a nurse 4 or 5 hours to put together that data can happen within minutes if a bot is accomplishing that. And it doesn't matter what system it is. But on the inverse of that, we're also seeing the payers want to automate that process as well, to gain more efficiencies on and I think in this specific use case, the outcome is going to be super positive for the patient, because if I have a patient and I can find out within minutes that geoplasty surgery can be accomplished and scheduled in room X while the patient is in front of me, and it's going to be paid for, then, or it's going to encompass that period of care, then I'm going to lose, like I think it was like about a 26% leakage of patient loss scenario. So when the patient walks out of the room, they just never come back. So I'm capturing that patient as they're sitting in front of me and being able to schedule, and the likelihood of them following up on that is much greater than it is if they go away and it takes me a week to 2 weeks to be able to get an answer to that patient as to if we can do the surgery and where are we going to schedule it at. So I think that hope that answers your question, but I believe that as we look at these more complex processes, which are things like prior authorization, those are things that are going to have the most impact on patient care and the financial bottom line for our health systems.
I heard yes. So I don't know if it answered my question. Sean, what's your thoughts on how value-based care is affecting, the market and RCM in general?
Yeah, absolutely. So I'll start with yes. I think RCM is going to be around in some way, shape, or form, even in value-based care world. If you think of value-based care, there's really a spectrum there, right? Everything from capitation all the way on the left, which I think Leah was referencing a little bit, but also bundled payments and kind of tracking through an episode of care across various care settings. Think about the role of RCM in that bundled payment scenario, trying to aggregate all that data, understand reimbursement, what entities or what steps in the process get paid what in that episode of care or that bundle is actually a really, really complex thing. And if you think about the core plumbing of healthcare that exists today in terms of data exchange, the claim is kind of still king in how payers and providers interact, how data is exchanged. And while certain standards may supplant that in the future, for a long time, that's going to be kind of the backbone of how we think about these adjudication scenarios. So I think RCM may evolve. I think analytics comes into play, but I think in some ways, adjudicating in a value-based care world is significantly more complicated than a fee-for-service world. And I do think that RCM has to evolve with that, especially as we are probably going to be in a long time in this situation where our clients and our providers have one foot in each canoe, right? We have some volume throwing through a value-based care world in certain specialties or certain types of bundles, and we have a lot of our revenue flowing through a fee-for-service world. And how do we help clients manage that kind of duality where the incentives in one are disincentives in the other without maintaining their bottom line and staying in business?
Very helpful. So we got a question from the audience around blockchain. So I know I'm the moderator. I'm going to give you my opinion first, but then I'm going to ask you to agree or disagree, which is blockchain has been something with great potential, but kind of a solution looking for a problem. So the question they asked is, will blockchain enter into RCM? I want to narrow it down a little bit. Where, if anywhere, where do you see blockchain coming into the fore to play a part in RCM? Andrea, we'll go to you next. Melvin, looks like you're ready to answer, so we'll start with you, and then we'll go to Andrea and then Andrew. Leah? No. Okay, Leah's just saying no. We got the mime Leah that says it ain't playing. Melvin? So no.
So here's I struggle. I have your same opinion, but I do believe that if you look at blockchain from its base standpoint, is that you have verified answers on both sides of the aisle, if you will. I mean, will my dentist take Bitcoin? I don't know, but that being said, I think that there's a space for it. I just don't know personally where I've not seen an application that said, oh, that solved a big problem.
Exactly. Sam, you're muted.
Anyone want to help pour blockchain out here?
I kind of feel much like Melvin does, that it's yet to be determined, right? So we looked at it as a company, as Allscripts quite a while back as it became part of the market. And the verdict is still out. And if we thought that there was a golden ticket right here in front of us right now, we would be seizing that opportunity. There just seems to be so many other technological advances that we can do that help in patient care and automation and in profitability of our provider practices and businesses, that it's just not been one, blockchain's just not been one of them that's made it anywhere near to the top. It may one day, it's just not there today.
Andrew, Andrea, either one of you want to rescue blockchain? Tell me you're using it tomorrow.
Probably not. We're probably a long way out from using blockchain. You said it's a solution looking for a problem, and I think that that's pretty accurate. When we find the right problem, we know, it's there for us. So the knowledge of it, the understanding of it that we've gained over time, it's really going to help us when the right problem comes up. innovation is all about timing, right? So we have these knowledge bases. We'll be able to access them when the right time comes.
I will say that there's a number of coalitions that are forming. I'm not sure that they're going to make a huge difference between both providers and the plan side. And some of them, like the Health Utility Network, are relying on blockchain for a multi-part record. So that's the only area I would say right now to your question, that if there's clinical data, something Melvin mentioned around prior auth, it may pull from a blockchain source, but it would still need to work through. I'll just add that as a moderator side comment. Moving forward, health equity, huge issue. And when we talk about equity, we talk about access to care. And sorry, HFMA, I'm going to go back to the HIM side for a second. When we talk about that, we talk about the telehealth rise. I just want to go back to telehealth for a second. We also talk about health equity along lots of lines, including digital lines. What is your company or your customers, how are they dealing with that digital divide, whether that be age, whether that be income, whether that be access to broadband? Like each of you to kind of, and this time I want everyone to jump in as you feel moved, but how do you see us getting over that digital to get access to, say, behavioral health or other resources that we want to do via tele, but there's lots of other divides, including literacy, digital literacy, and health literacy, combine the two of them, and you have difficulty. And are there any solutions out there that you think, wow, this will really help that, whether they're from your company or not? Andrew, why don't we start with you?
Yeah, interesting topic for sure. I would take it back to AI, and in particular, exposing bias in models. I mean, that's been a big issue of late. I think the importance is kind of moving away from a black box type model where you get an answer of of a risk, for instance, for a particular patient, and more towards transparent models where you get some reasoning behind how that risk was assessed, so that you can take into account some of these different factors. So I think one example of where Microsoft is really focusing is on that data side, and can we be transparent about how these results are being computed, as opposed to just giving you an answer, because those tend to be where the biases creep in.
Going around, Andrea.
That question is really tough, I think, but thank you for challenging us with that one. I think that when you deal with people that might not have as much access to technology, the key is keeping the traditional paths of getting knowledge, keeping those open for them and keeping them accessible. So if you have a person that doesn't have access to an app to check on their test results, you have to make sure that there's still a person there, that you're asking that question at the point of contact, and that they're making a phone call to provide that information to the patient. So just understanding that technology does not always replace face-to-face interactions, and that we have people looking for different levels of interactions.
Sean?
Yeah, I think Lee answered it, or I'm sorry, Andrew answered it very well. I think we can't race to a lowest common denominator where technology is the be-all end-all, especially you think about rural health and maybe where we don't have access to broadband, or even if they have access, maybe just the technical fluency isn't there, right? If we think of elderly populations or others, it might just be foreign to an iPhone, right? We need to make sure that as we modernize our healthcare infrastructure, we do leave a path for high touch individuals, maybe focused on segmentation or clustering or using data to determine how we should reach out to those certain archetypes or personas of patients. But we really need to make sure that approach is all inclusive and doesn't rely on technical future holistically and without bias.
Leah, I know you answered part of that in the chat already, but you can just repeat that or change your answer.
Yeah, I believe that we have to have our providers continue to have inpatient visits. And it's not just for the equity of the population, but I think just reasons that you will always want to have face-to-face visits with providers. And, your cardiac surgery is one of them. But while we have those patients in-house and we're having dialogue with them, that is where we need to start earmarking our patient records and demographics with information that helps us manage those populations and those patients going forward. So within our products, we need to be determining then and asking the questions about those social determinants and collecting it so that we know going forward. And then we need to, as I think Andrea said, we've got to keep those paths open. We can't shut down physical patient care. I also don't think you can shut down phone calls to people, because the least common denominator for most of these people is having a home phone. So that still has to be maintained, and so there will be that need going forward. But I think it's a large issue, and it's not just healthcare, but communities, families. We're all going to need to collaborate on how we solve these social determinants and how we provide care in all these venues. And I like the comment of not seeking the lowest common denominator, because now we have 3-year-olds that are working iPhones, and those are going to be our elderly population at some point. And so we've got to continue evolving, and we can't ignore that. That is a big demand out there, is technology and, immediate gratification, answers, responses to so many things. I mean, what has happened to the taxi industry? If you don't get the service that you want, you create it, right? And if we as healthcare providers and as technology people don't evolve with the mass part of population, they will create their own. And I think we've seen that with retail space, with Amazon, right? So if we don't provide the experience that the majority of the population needs, we're going to be left behind as well. So we all have to work at how we service that population, but knowing that population exists and how to reach them and asking those tough questions when we have the chance to do that, and educating them and understanding where their limits exist is really, really important, so that we can mine that and we can aid that population going forward.
Melvin?
Yeah, I mean, I think that we've covered it in pretty good detail. I think that technology will play a role from this point forward, but I think you still need the bookmobile. You need to be able to drive in and I'm from Central Kentucky and very close to Appalachia, and some of the only way you get there is by going down and setting up a remote CT scanner in a Walmart parking lot and letting people come up, and that's how you deliver care in those places. So I think it's here's what I would say is that as you think about the delivery of care, is that how do you deliver care to that individual, and then that's how you deliver care. That individual being how they consume it, whether that's through an electronic, whether that's through a Walmart parking lot, whether that's through a brick and mortar. And I would say from an HFMA perspective is that how do you bill and adjust your billing associated with the level of effort that it is required to deliver that care? So can I increase my payments specifically for the Walmart parking lot, whether that be from a Medicaid perspective or a Medicare perspective? So, those are my kind of thoughts on that. As we move into our last chunk of our event, I did want to ask a question, being the fact that I work for an automation company, and the question I get asked most, and we helped found an organization. I would invite everyone to attend. It's called the Healthcare Intelligent Automation Alliance. It's for hospitals only. No vendors are on there. It's just so you can get on and talk to other people and see what they're doing. But to Sean and Andrea, as I think about where so many people started in automation, how have you evolved in where you started and where you're at today? What was that journey like? Because I know that in most cases, the health systems that I work with, they start with like, okay, here are the 5 robots that I'm going to work on, and then we get that going, and either some will just say, okay, we automated, yay, and then they walk away, but they're not really tapping into the full potential. So I'm curious about your all story.
Sure. Can I go first, or?
Yeah, Andrea, why don't you?
So we started by looking at getting better information from the payers, getting more information about claim status, getting more information about eligibility, authorization, and we've been able to gradually move that along. One of the things that I saw was the most important is making sure that you're focusing on value and that you're constantly talking to your stakeholders on the operations side. Something that I see happening a fair amount is people in IT getting segmented. You're only in IT, you develop this, and then you send it to us. And they're not necessarily in the conversation with the business side. And that's really where things start to fall apart, because your operations team is a wealth of knowledge on all of these subjects. And when you bring them into the process and you're consistently getting feedback, you wind up with the best product. Innovation doesn't happen in the IT department. We're just actually making it happen. Innovation is happening on the business side, where they're seeing what the problems are and how you move them forward. So we've been able to take things not only from the perspective of getting more information from the payers, but of automating what happens when that information comes back in, what the next step is that you take with it, and then saying to ourselves, like, well, how can we help you guys even more? We've helped you this far, how do we help you even more? And getting that answer back from your team.
Yeah, I would agree with that, Andrea. I think as we at R1, we knew that this was a game-changing technology for us, just given how many rote manual tasks we know are within our operations. And one of the interesting things is our built-for-purpose workflow layer provides a single pane of glass that all our staff work in, and that throws off, I'll call it digital exhaust. So we know every activity that every person is taking, our 20,000 strong client base or user base across all of our clients. And we use that to really take a very methodical look at what's every activity we do in the revenue cycle, how many times those activities occur, which are very, I'll call it repetitive, and therefore we should put those at the top of the funnel for automation. We took a very, though, I'll call it top-down COE-based approach to automation versus some others that I've talked to take more of a federated, so out in the field, consumer citizen developer approach. We said, no, we want to run all this at scale. So we stood up a COE, I think it's 120 plus person strong COE at this point, that brought together digital process mappers or business analysts with operational SMEs, with developers, and then wrap that into kind of a central support team that can support automation at scale. Well, we launched this, I'll call it digital transformation office about 2.5 years ago. We've scaled from automating very little via RPA technology to now automating well north of 30 million tasks on an annual basis through our digital fleet. About well over 1,000 FTEs worth of work every day is automated with this technology within our ecosystem. But I do think, so I saw one of the comments in the chat, it really isn't necessarily about cost savings and cost takeout, because we as a company are growing so fast that all we basically allowed to do is we deferred hiring for the next client that we brought on. So we said, all right, if we have 100 billers and we can automate 20 FTEs worth of that work, we're just going to reallocate the higher value tasks for another client's work and just kind of defer hiring for that growth. So, and that was actually a really important message, Melvin, to your point around how do you make the organization excited around automation, right? And not have it be about cost cutting, but have it be about innovation, quality of work, accuracy. I think it's been a really good story for R1, and our staff and our employees have really kind of resonated with that message.
Awesome. So we have reached that part in our where it's almost time to say goodbye. So we've reached what I call the speed round. Each of our panelists, I want you to tell me, if we're holding this conversation, I'm not going to make it too far out, but far out from a technology standpoint, 5 years from now, what is the thing that we didn't think of to ask today, or weren't aware of, or it's on our periphery, that's going to fundamentally change the patient or consumer experience and will fundamentally rock back into our current world, where we'll be doing something in a way that none of us could live without and we couldn't imagine happening? As you're all contemplating the first one to look up, Leah wins the prize. Leah, you get to answer first, which gives all the rest of my panelists a little more time to come up with their answer. 2 sentences, make it a 2 or 3 sentence answer, Leah, nothing long.
I think it's the exam room of the future, whether that's a home or whether that is a doctor's office. But what does that look like? How do we enable our providers to be the smartest people in the room, virtual or not? And how do we collect as much information real time as we can during those visits without having to physically touch or to scroll through technology? Someone else go. Are we going to pass the baton? I'll pass it to Andrew.
Open heart surgery at home. No, I really do think that I loved what Leah said, and using technology to return the art of medicine is, I think, huge. Taking some of the stress and strain. I think there's mental health issues on both the provider and the patient side of the spectrum. What we can do to really intelligently use technology to head off some of those problems will be key.
Andrew, you get to choose the next one.
Sean, please.
Sean, you're up.
Thanks, appreciate it. I think we've talked a lot about automation, but we haven't talked a lot about augmenting the human capital we have within the revenue cycle and within the clinical realm. So I think if I look 5 years ahead, I think that AI machine learning models will be just ubiquitous across both our administrative as well as our care settings, and they won't be replacing physicians or replacing administrative staff. They'll be augmenting them, to Leah's point, to actually letting them, make decisions, in more informed decisions, bring the best information from all the clinical journals that there's no way they could all keep up with and read, but bring those kind of real-time insights to them just in time to really impact care delivery. And I'll go to Melvin.
Melvin, you're up.
Excellent. Yeah, great answers from the panel. It's a really interesting question that you proposed, and what don't we know about the future? I'm certain that I'll have a chip in my head, and they'll just be all that information will be going to Kroger, so they can not only get my care taken care of, but also get some coupons for jalapenos. But at any rate, as I think about what's going to come, what's going to change, I do like the concept of the exam room, meaning that you can get care wherever you need care and whenever you need care. I still think back, I was in the Ozarks with my family, and my daughter got pink eye, and we were like, how are we going to get this done? So opened up my phone and had a telehealth session right there. So it's get care whenever, wherever you need to. And I think that's, and how we execute that, that's what I want. I can't wait to find out.
Andrea.
Yeah, I think in the future, everything that I've heard so far, I definitely agree with. I think we're going to see more of a concierge style in healthcare, because it's going to be so much more patient-centric. The story isn't about us and the technology side. The story is about the patient, and everything is going to become more patient-centric than what we're even seeing now.
Fantastic. So I want to thank New York HIMSS, New York HFMA, and thank our wonderful panel. Thank you for your participation and your good humor throughout. I think the world you painted in your last answers would be one that all of us would benefit from. And let me turn it over to Tony Ferrante to close us out. Tony?
Thank you, Sam, and great job as a moderator, keeping everybody on their toes and making sure that we get our prescriptions from Kroger. I think that's really important. And again, thanks to the folks at HFMA and also participating with us on this, and each of our different panelists here, Andrea, Leah, Andrew, Sean, and Melvin. Great job today. We really appreciate it. I think all of our members from both the HIMSS and the HFMA chapter will benefit by this. Please come to our website for some of our future events coming up. On the 1st of April, we have the folks from Haney's will be laying out a program I think will be very exciting. So come and join us for that. And then we will have the rest of the next couple of months, we have a series of other exciting opportunities for our members to learn and to share. Again, thanks to everybody. And come to our websites, both HFMA, Metropolitan Division, and to the HIMSS New York State chapter. Come and become a member. And this way, these events will be on your calendar on a monthly basis. Again, everybody, thank you very much. Nick, thanks for being a good producer. and we're set to rock and roll. Thank you.
Bye, guys.
Thank you.
Thank you, guys. Bye-bye.